I am a board certified patient advocate with over 30 years of experience working in healthcare. And it is a distinct pleasure to transition to becoming an advocate, working with patients and families and helping them negotiate some of the difficulties that they face working with providers, doctors, clinicians, insurance companies, understanding what they're going through and basically understanding all of the information that one needs to be proficient in making good, informed decisions about one's healthcare. So it's a challenge, and typically as advocates, we meet families when they're in crisis. The discharge from a hospital, whether an emergency room or from an inpatient stay, is one of the most dangerous times for a patient. If you think about it, when you're transitioning or passing off care from one team to another, from one setting to another, the opportunities for miscommunication, for misunderstandings, and errors are exponential. And the role of the family is critical in serving as an advocate and a liaison between the teams. So what are the risk factors to consider? In general, they start with on the day of discharge. It's a very collapsed time frame for making decisions for patients and families. Oftentimes, the clinical team, whether it's in the emergency room or the hospital, has been working on and preparing the discharge plan for days, but the family is always somewhat surprised when it's time to go home. They may know it's coming, but they still are looking for answers to clinical information that hasn't been shared with them. There's a general lack of understanding as to who does what in the hospital. So a lot of times families and patients are waiting to hear from a doctor. And unfortunately, the doctors aren't the ones that handle and manage discharges. Ultimately, they don't understand their appeal rights. They don't understand that whole process. So they're told what they have to do. And if they aren't in agreement, then they're going to have to pay privately. Now, oftentimes the notification to families come within 24 hours. So they have a financial incentive to discharge people out quickly. Coordinating care and patient needs is always a complicated process. Families are often put into a position where they have to make choices about placement, whether it's either to a level of care like a skilled nursing facility, rehab center, or assisted living, or they have to take them home with home care. And they really don't understand the process, the choices, the options, the different types of agencies, whether it's home care agencies or skilled nursing facilities, where to get information, how to evaluate them. And again, the collapsed time frame and the stress created by this whole process often causes families to be overwhelmed and incapable of getting the information they need to make informed decisions. And they often feel put upon by the hospital staff because the short time frame. Hospital staff themselves are often overloaded with work and responsibilities and don't have or take the time. And a lot of these things end up happening on Fridays, and Friday discharges Friday is like one of the worst days to be discharged, because if you're transferring to another level of care, you're hitting them at a time when typically they have the lowest levels of staff on a Friday evening. It's alternating staff, so they have fewer staff. That's where the call-ins happen. And anybody who knows anything about healthcare knows it's tough to get anything done on a Friday night. Another area of risk factors is the access to clinical information and staff. Oftentimes families are confused as to who's in charge. And they talk to the nurse, she gives a little piece of information. Doctors, any number of specialists come in and out, and you try to approach them for information, and each one will glean a little piece of the puzzle, but nobody's really pulling all of it together so that it's understandable and it's cohesive. Oftentimes you ask questions and what you'll get back is, let me go check, I'll be right back, or I'll get back to you, let me call the doctor. And nobody ever gets back, because that becomes the way you handle those things, is you say, hold on, I'll be right back. And then you go get distracted by 12 other things. And again, staff is overwhelmed as well as families, but that doesn't take away their obligation and responsibility. They still have a role and a responsibility to answer questions. Then the other question is, where's the doctor in all of this? Because the doctor comes in and does their assessment or evaluation, but typically they're not around to answer questions. And oftentimes they're back in their office doing office hours. Oftentimes there are unexpected changes in care, and families are become aware of it when the change happens, but they're not given a heads up, and they may not even be given an explanation as to why that happened. Oftentimes information is confusing because many family members don't have a clinical background. They experience information overload. And then right at the time of discharge, they're handed a packet of information and told, here you go. While they're stressing all of this, they're expected to read, a 1-inch thick packet of information related to the discharge. Oftentimes families don't understand the role of hospital staff, who does what in the hospital. With emergency room physicians, their primary objective is to stabilize unstable residents coming in, and then they turf them either into the hospital or back home to the community or wherever they came from. So the idea is to treat, stabilize the acute episode, and return them home. It used to be that primary care physicians from the community, if you were admitted, your doctor from the community would go and take care of you while you're in the hospital. That doesn't happen much anymore. Instead, hospitals hire doctors through an agency that are called hospitalists. And their job is to facilitate and coordinate the care so that they can discharge you from the hospital quickly. The hospitalist works for the hospital. He definitely coordinates and directs the care, and typically will write all the orders, but he works for the hospital, and he or she is paid by the hospital. And so the primary objectives of that role is for the hospital. Physician extenders like residents, PAs, even nurse practitioners to an extent, oftentimes just complicate the matters because you don't know who's doing what and what role they have and what level of care, training, or knowledge they have. And that just confuses it because it's more people as part of the team. In virtually every hospital, there is a care coordinator appointed, and it's typically an RN. And that care coordinator is the person responsible for coordinating the care plan for each resident on their unit. Unfortunately, a family member was hospitalized last summer, and we met the care coordinator while we were waiting for the transport aide to take us down to the lobby to leave. She introduced herself, very polite, very lovely. The problem is we didn't even know she existed until we were leaving. She was telling us who she was. And she assured us she had been following our care throughout. Well, we had a million questions and never had the opportunity to ask her those questions. Never got any conversation with her at all until we were leaving. And I believe that that's by design, because they're very busy, they don't have the time, so they schedule it, drop in to do their hello, not in the beginning of your stay, but at the very end, because they have to be able to document that they met with the patient. I didn't know that until recently. Social workers typically are the advocates in the healthcare system for their patients. In hospitals, they are discharge planners. That's what they call them, and that is their role, to help facilitate the discharge. Once the discharge is effected, they're done providing any service to the family or the patient. And then last but not least, hospitals have patient advocates or patient representatives or ombudsmen. And often these are hospital employees, and they basically are troubleshooters, and they can provide an invaluable service for many patients, but they aren't independent of the hospital. They work for the hospital. They employ and implement the policies and procedures of the hospital. And they're really good and effective troubleshooters and problem solvers in the best hospitals. But again, they're not independent advocates for the patient. And that poses a concern and a potential compromise. One final risk factor is that there's little knowledge or understanding of the discharge process. It's a mystery. It just happens really quick. It's kind of thrust upon families and patients. The discharge paperwork, that packet of information, includes a discharge summary, which is written typically by the hospitalist or the doctor in charge at the hospital, a list of current medications, which may be different from the medications they took prior to the hospital stay. Almost always they are. Treatment plan and instructions. And this is an area where we oftentimes, where hospital staff fail to provide the necessary time to employ a very effective technique called teach-back technique, where you teach something and then you have the person repeat it back to you to verify that they understood it. And that doesn't happen in the discharge process. Instead, they shotgun a ton of information your way and say, any questions? They're not really that concerned with whether you understood what you were given, just that they gave it and that you have it and that you're heading towards the door because you're being discharged. There's typically a list of referrals to specialists, and then any special care needs, whether it's equipment or special instructions for anything and everything in nursing care, rehab care services, or whatever, oxygen care, respiratory care. All of that will be included and provided in it. And there's also one very important document called the Determination of Coverage Notice. And that is the determination that you no longer need hospital care or that level of care, whether it's an ER stay or it's an inpatient hospital stay. It was originally set up by Medicare and followed by all insurance companies, and it's now a standard document throughout the industry, throughout the country. And basically, it explains why you're being discharged in very administrative type terms. On the back side of that is the required notification that of your rights to appeal the determination to be discharged. And the big question is, and I'm often asked this by families, is how can I stop them from discharging my mom? I don't think that it's safe. What do I do? And I ask if they've found the discharge appeal. And in 100 out of 100 cases, what I hear is, what is that and where would I find it? And it's in that big packet that you can file an appeal by phone. And that's on that discharge notice. And that's one of the things they've created. The federal government has actually created a process that ensures that the rights of a person to appeal a discharge, or an adverse determination, they call it, can be done immediately. And the appeal can be made by phone to a third party. And the third party is available 24/7, and they will respond, and they typically will take, if there's any valid reason or concern whatsoever, they will put a hold on the discharge until they get enough information to make a determination as to whether they agree with the hospital that the discharge is appropriate, or they disagree and the stay will continue. When you file an appeal immediately, that puts a stay on the discharge. So if you're sitting in a facility and it's 5 o'clock on a Friday, and you don't think it's right that mom should be leaving at this point or going to a nursing home on a Friday evening, and you have your concerns about the safety and well-being or the lack of coordination that's going on, you make a phone call, you find that determination of coverage notice, flip it over, get the phone number, make a phone call, and that starts an appeal process, and it pens the discharge until that reviewer makes a decision as to whether or not the discharge is safe. And trust your instincts. If you think there's something wrong, there probably is. So what can go wrong with a hospital discharge? Well, certainly either poor planning or a lack of coordination of the planning, the decision-making. People have been sent to the wrong level of care. Clinical expertise isn't available on site. There are unexpected costs. The facility is out of network versus in network, so there might be out-of-pocket expenses. Or, their families are told, pick one of 3 nursing homes. We're going to send her to a nursing home, pick one of 3. And if you don't pick, we'll send her to one. And it just has to be within a 50-mile radius. Well, in New York City, that could put somebody 2.5 hours away. The reality is that there's a lot of pressure on families, and they are expected to figure out where mom is going to go or where dad's going to go in a very collapsed time without the ability to really exercise due diligence to find out more about these facilities. And information's available, but it takes time. The discharge itself could be unsafe or inadequate. And I point to Friday discharges or discharges to facilities that have insufficient staffing, or they don't have an on-site pharmacy, so there's going to be a delay in getting medications, or they have a really poor performing facility and it just doesn't provide good care, and there's a history of it. Other factors that can go wrong are there are changes in medication. I know from a personal experience, I had a family member that was discharged to a nursing home, and when she went, she had 3 different orders for her Parkinson's medication, and unfortunately only one of those orders was picked up on the med sheet when they transferred the information to the nursing home. So 2 days later, when she started serious tremors and she deteriorated rapidly, and the Parkinson's literally wreaked havoc with her body physically, that's when we realized she was only getting one of her 3 Parkinson's meds. Human error. It's a communication error, and paperwork is paperwork. And again, you're picking information. You got a whole new team picking information up from a team that doesn't know her that well to begin with in the hospital. So the coordination between doctors, scheduling care, there can be delays, such as home cares. And there are oftentimes barriers to accessing community resources like transportation needs or access to doctor's offices. And today in COVID, we've transitioned from getting to the doctor's office to doing televisits. Not exactly the same as a good physical examination. What can family members do as advocates to make hospital discharges safer? The first, anytime somebody is admitted to the hospital or an emergency room, it's start the discharge planning process first. Have that foremost in your mind that this isn't a permanent placement, and ask questions of the staff at all levels about the discharge process. Get that conversation going with all of his or her principal caregivers, so that you can become educated about the needs of the patient from the beginning. In healthcare, everybody looks at clinical protocols based on diseases, clinical conditions. That's how clinical teams provide care. And there's a long history of potential outcomes. Doctors and nurses should be sharing this information, but for the lack of time they have, oftentimes it's not shared. But if you ask, they will provide that information. As a family member, visit on a daily basis and take notes of the conversations that you have with people. That's the best way that I know to get a clear picture of the history. And you can use your notes in conversations with subsequent clinicians. And involve the community doctor if you can. They can be a tremendous advocate negotiating the hospital. Even if they're not providing care in the hospital, they can talk to the clinicians. And now you have somebody that's an advocate for your relative while they're in the hospital that is talking from his or her point of view as a clinician to the clinical team. It is very powerful advocacy to have the primary care physician get involved in the care and ask questions. Ask to meet with the case coordinator or case manager. Ask who the RN case manager is and ask to meet with her or speak to her or him. Just the fact that you know that this position exists and you ask to meet with them is going to open up that dialogue and start the communication process much sooner, the way it should happen all the time, but rarely does. Anytime you feel that there's an unsafe discharge, file an appeal immediately. And if you're not sure and you have concerns about it and you're not comfortable doing it alone, hire an independent board-certified patient advocate. I strongly support the independent advocates simply because they've been there, they've done it for families, and they can kind of whip you through the process very quickly, get you up to speed, and help to make sure that the discharge is a safe discharge, and that you understand and are able to make good use of your rights and exercise your right to appeal a discharge, particularly if you believe it's unsafe. The Making Hospital Discharges Safer links page, the discharge placement options for skilled nursing facilities, Medicare, the Nursing Home Compare website, that's the federal website, and New York State Department of Health has the New York State Nursing Home Profiles. The feds also do the same thing on the Medicare website for home care services, and the state does the same with different types of home care programs in New York State. And again, the feds do it for hospice agencies, as does the state. In going through the discharge paperwork, sometimes if you're not sure, you can click on the Center for Medicare Advocacy. It's an independent, not-for-profit, and they outline in about 10 or 12 pages, they outline the entire discharge planning process and the responsibilities that hospitals have. If you read it, all of a sudden, things that you see happening that you don't understand will suddenly make a lot of sense. It's very helpful for consumers to read through that, and that's an invaluable information. And last but not least, if you're going to hire an independent board certified patient advocate, you can contact the Greater National Advocates Association. You can contact the Advo Connect, or you can call me through my website.